Harvey Risch, professor of epidemiology at the Yale School of Public Health. He wrote a controversial op-ed in support of hydroxychloroquine. Dr. Risch, thanks so much for being with us this morning. I do appreciate your time. Why is it that you think Admiral Giroir, who you just heard right there, not to mention Dr. Fauci and Dr. Birx, are wrong about what they're saying on hydroxychloroquine?
It's nice to be with you, John. So as of now, there are 12 studies that show that hydroxychloroquine plus zinc and other companion medications, when used early in high-risk outpatients, convey significant and substantial benefit in reducing the risk of hospitalization and mortality. That's a very precise statement, which has very precise conditions for who are the people that need to be treated and how.
Let me just jump in here so people know what you're talking about, because when you wrote in the Newsweek op-ed, it was 7, now it's 12. None of those studies that you just cited are random, placebo-controlled trials, what Dr. Anthony Fauci refers to as the gold standard. Listen to Dr. Fauci.
Any and all of the randomized placebo-controlled trials, which is the gold standard of determining if something is effective, none of them had shown any efficacy for hydroxychloroquine.
The random placebo-controlled trials, none of them have shown efficacy, correct?
That's not actually correct. The problem with those randomized controlled trials is they were trials done on the wrong people. They were trials done on low-risk people who have very, very low risks of hospitalization and mortality. So you don't do a study of prostate cancer in women to prevent prostate cancer in women because nobody's going to get the outcome. And that's what those studies did. The Bulwer studies and the Mijah studies in Catalonia, they were all on very low-risk people who are not going to get it and hospitalized, or die by and large, and we don't treat those people. We treat high-risk people.
Well, look, okay, to that argument, again, your paper in Newsweek goes on to suggest the problem is they're not being tested, hydroxy is not being tested on outpatient people, not hospitalized people. So a little shift in your argument there from what you wrote in Newsweek already. The fact of the matter is...
I'm sorry, I think that's a mistake.
The fact of the matter is there are studies out, these random placebo-controlled trials, including the one just published in JAMA. The one was published in JAMA before from University of Albany, and there was one published just a few days ago that comes out of the University of Minnesota. It's tested on people early on in the process, correct? Which is the same type of trial that you were citing as proving benefits. Again, there are no random placebo-controlled trials that show a benefit, correct?
No, you're misstating what I said. I said it had to be in high-risk people. In fact, in my Newsweek paper, as well as my American Journal of Epidemiology papers, I said outpatients, high risk, people over 60 with obesity or diabetes or cardiovascular diseases, those are the people who get treated. Young people with no conditions don't need to be treated by and large, unless in rare cases they present with shortness of breath. They don't need to be treated. But those were the people who were studied in the Bulwer, Minnesota trials and in the Spain trials and so on. So as I've said, you have to treat the right people and you have to study the right people. Those studies did not study the right people, period. That's the bottom line.
The study published in JAMA published a wide range of ages and people in different situations, and they were given the drug over different times. Again, the question is, why haven't any random placebo-controlled trials showed benefit? And isn't that a problem for an epidemiologist?
No. In fact, the FDA has a huge history of drugs going into widespread use in the medical community for decades that have not been established on the basis of randomized controlled trials. Half of the chemotherapy drugs used in cancer were used without randomized controlled trials. The antibiotics, amoxicillin, for example, that parents use with their children all the time, day in, day out, was never established with a randomized controlled trial before it was used. We have a whole vast medical literature that was not the standard. So why is it suddenly the standard now when there's other reasons?
I don't think it is suddenly the standard. That is the way the FDA operates. It's the way that Dr. Fauci operates. And I've been speaking to a number of epidemiologists over the last few days who also are frankly shocked that you've moved the bar so much on random these randomized placebo-controlled trials. Let me just read something, what someone wrote me. He said, while I can't dismiss this out of hand, in other words, he can't dismiss out of hand that maybe there is some benefit to some subgroup, for you to discuss it is irresponsible at this point without the public evidence provided by a random placebo-controlled trial.
Okay, so in the New England Journal of Medicine, the previous head of the CDC, Tom Frieden, discussed at length evidence beyond randomized controlled trials. Randomized controlled trials in the real world are not gold standards. That is a theoretical idea that does not play out in the real world. For example, in sepsis studies, nobody uses randomized controlled trials for medications to treat sepsis. That's standard, and the whole field knows that. Dr. Frieden explained that all real-world evidence goes into understanding the benefits and harms of medications, and that is a standard that scientists use. Relying on a so-called theoretical randomized controlled trial is a red herring, because that is not the way the FDA works, it is not the way scientists work, it is not the way anybody works in real world.
The benefit to these random placebo-controlled trials, as you well know, is that there is a built-in bias, or can be, in any trial that's not random. Because why? Because the people administering the test know what the person is getting, and they may treat that patient differently. In the Henry Ford study, for instance, the patients who received hydroxychloroquine were handpicked, and they tended to be healthier. They were also twice as likely to receive steroids, which are proven to have a benefit. That's why randomized placebo-controlled trials, which Dr. Fauci does refer to as the gold standard, are so useful. And I know you know that. And that is also what the epidemiologists, that's what the epidemiologists, including the ones I've spoken to, say is simply the standard for the FDA. And also, again, the issue here isn't, I'm not disputing that you have cited these other studies, these subgroups. I'm not disputing you've cited these studies which show a benefit in subgroups. But the problem is when put up against the random placebo-controlled trials, none of which have shown a benefit. There is a conflict there which has caused the FDA pause.
I'm sorry, but you have actually three or four wrong statements in what you said. First of all of those randomized controlled trials were not blinded. The people knew which medications they were taking because it was stamped on the pills. So to say that there's no bias in those trials is all red, and the people self-reported their symptoms. So to say that those were gold standard trials is just nonsense, because the same bias was present in those as in any other kind of potential biases in any other kind of study.
They were selected randomly.
No, that's not enough. That's not enough. Randomization does not make the subgroups perfect. It can push in that direction, but there can be residual non-randomization in studies, especially ones as small as the ones in the Minnesota study. Randomization is a theoretical goal. In real world, it does not work perfectly, and there can easily be confounding by lack of adequate randomization. You need tens of thousands of people in order to have randomization that works. In a few hundred people, it does not work.
Okay, again, the issue here is the conflict between the studies you're citing, some of which people need to know are a little sketchy. For instance, the Zelenko study, which you know is a Google Doc, basically, more than it is a study right now. And again, it doesn't meet the rigorous scientific standards that most people look into. And again, the issue here is that there's a conflict between the studies you cite and the random placebo-controlled studies. All the epidemiologists I speak to and Dr. Fauci say, if there is a large randomized study which does show a benefit, they will change their view. But up until this point, it doesn't exist.
As I said, the FDA does not stand. That is not the FDA's behavior.
But up until this point, none of those studies show that, which gets to the point of safety. Now, you write about this. It's interesting because you don't dismiss the safety concerns, which there have been proven side effects to taking hydroxychloroquine, even for people.
No, there have not been proven side effects.
Well, that's not true. You know, people with lupus and other things, there are known side effects. The issue that you write about is because you say there's a benefit, it's worth the risk. Well, but if there's no benefit, what the FDA is saying, it's not worth the risk.
First of all, there is a lot of evidence which you haven't even let me discuss. Secondly, the FDA has no evidence whatsoever for outpatient use of hydroxychloroquine of any adverse events. The FDA on its website has black letter warning saying not to use it for outpatients. And just below that, it says that it only has data for use in inpatients, which is a totally different disease. So the FDA has no data on outpatient use, and yet it put a black letter warning against it. That to me is just unconscionable that they could do that and allow 45,000 deaths in the month of July alone because of blocking a medication that they had no data on.
The data is the random placebo-controlled trials.
No, we're talking about data of harm, not data of harm.
No benefit. And what they say is because there is no proven benefit, the possibility of harm is not worth the risk.
They have no evidence of harm. And aside from the 7 studies of about 1,500 patients have shown handfuls of deaths, 2 or 3 deaths out of some 1,500 patients in which these medications have been used. There are 2 clinical trials, not randomized, but they are still clinical trials with adjustments for all possible confounding that you or I or epidemiologists could think of, all showing benefit. There's studies in the Pará state of Brazil showing that when they introduced 75,000 doses of azithromycin and 90,000 doses of hydroxychloroquine on April 6th, about 5 weeks later, after the medications began to be dispersed, the exponential growth of mortality plummeted to 1/8 the level of the peak because those medications were being given out in large force. That's the evidence that shows these medications work.
All right. Dr. Harvey Risch, we do appreciate your time. Thanks for coming on and discussing this. Be well.
Thank you. So the first thing is that Dr. Fauci has been maintaining that only randomized, controlled, double-blinded trials provide evidence worth relying upon to decide whether a medication works. And that is a standard that has never been imposed neither by the FDA nor by the scientific community in general. The large number, if not the majority, of medications used for the last 50 or 70 years across the world were not established by using randomized controlled trials. A lot of combined chemotherapy for cancer was never established by using randomized trials. Antibiotics, as I said, amoxicillin, which is billions of prescriptions of amoxicillin for every time a child comes down with strep throat and you get a prescription for it. That was never established with a randomized controlled trial. Dr. Frieden in the New England Journal said in a long essay, here's how you evaluate evidence for something. It's not just randomized trials. They have flaws and failures in the real world. You take that into account when you evaluate their evidence, and you also look at what are called phase 2 information, which is all the non-randomized trials and other evidence. And that is all part of the thinking of evaluating evidence, which is what epidemiologists do day in, day out at looking at science. So the first point is that all of the evidence needs to go into this discussion, not just a shibboleth of randomized controlled trials or nothing. That leads to what is the evidence. The evidence is that there are now 12 studies looking at the use of hydroxychloroquine plus additional medications. It could be zinc, it could be azithromycin, doxycycline, steroids, and so on. All of these are in use in various places that have been studied. Then you have the studies of patients actually treated. Now, when you say a study is anecdotal because it's a case report of 1 person or 2 people, that's what anecdotal means. But when you do a case control study where you interview 50 or 100 or 500 cases of a study, that's epidemiologic work. That's a case control study. Here, what we have is the case part of case control studies. So these were studies of sequential patients that were treated with hydroxychloroquine and azithromycin, zinc, and so on by various clinicians across the United States that showed tremendous benefit. Much more benefit than the trials because these were patients who were being treated individually, and individual treatment is not formulaic. Individual treatment is giving the prescription, seeing how the patient does, adjusting it on a day-to-day basis as you need to get the patient better. And these studies show immense benefit. The study by Dr. Zelenko, his first 405 patients with 2 deaths. His second study with 400 patients, no deaths. 6 or 7 other clinicians across the country, again, with a total of 500 patients, no deaths. These are all high-risk patients who had probably a 10 or 15% mortality risk if they had not been treated, and no deaths. Now, people say, okay, well, those are people you found out about. Those are clinicians that you found about because they had such good results. They came to you to tell you how good their results were, but they're not representative of how treatment goes across the country. Okay, so that's a theoretical argument. But let's say we do this. Dr. Zelenko and Dr. Proctor in Texas both reported to me their initial series, the first 405 of Dr. Zelenko and the first 50 of Dr. Proctor. And then they said, you know what? We'll go and we'll get more patients and we'll treat them and we'll show you how good it works. And Dr. Zelenko did exactly that. He treated another 400 patients, no deaths. Dr. Proctor, another 50 patients, no deaths. Now the question is, what is the probability that they could have done that now that you're saying, here are the people you're actually going to look at. Here are the doctors you're actually going to look at. The probability of them doing that is less than 1%, and probably 100-fold less than 1%, with the risk that an untreated patient at high risk would actually not get hospitalized or die. So there is very substantial evidence that these drugs work dramatically.